Okay, so here we are, chapter 7. This is still in the advanced. Every video I tell you how important it is to do this next step textbook because it takes you from the basic coding of the 321 coded book into a more advanced, higher level of coding, which I think will serve you very, very well on your board. So this is chapter 7, digestive, hemolytic, lymphatic. Again, let me get my glasses on because I'm old. Again, a little bit of the wordy stuff. The wordy stuff in this book, it's primarily scenarios, but the wordy stuff in this book really is concise and very focused and can very much help you with some of your notes that you put either in your CPT, ICD-10, or HCPCS. They do incorporate some of the diagnosing in here, the diagnosis codes, the difference in these. This is talking about different intestinal obstruction diagnosis codes. So this case 1, remember all of your odd answers are in the book. The even ones, if you will email me or leave a comment, I will help you with those. This is an inpatient consultation. Always read your italicized. This one's probably pretty straightforward. This is an inpatient, so we know it's not an outpatient consultation. Remember, there's 2 kinds. And then I imagine they have a bowel obstruction, chronic bowel obstruction. So that would be the information you needed for that. Here's an OpReport for an anal fistula. Let's put this a little, okay, so they're going to do a fistulotomy. Otomy meaning cutting into. The fistula, they're using an anoscope. I think that one's pretty straightforward. That one's pretty easy. You always go with the post-op diagnosis, not a pre-op. So anal fistula will be your diagnosis code. Here is a case for intersphincteric abscess. They're probably going to do an incision and drainage. So let's see. There's your diagnosis code, intersphincteric abscess. Patient is placed under, so they are doing anesthesia, drainage of a perirectal abscess. So that's it. So this is an incision and drainage of an abscess in the anus. Perirectal fistulectomies. So this is removal of several, ectomy meaning removal. So your diagnosis code here is going to be your perirectal fistula. Hemorrhoids, you have different grades, great pictures. It's great. 7.5 is a hemorrhoidectomy. Remember, all of your odd answers are in the back. Then we're getting into different catheters that are put in. And there's lots of different kinds, from feeding tubes to colostomies, which is elimination tubes, to peritoneal catheters that could be for drainage of pus or peritoneal dialysis, all kinds of different catheters and tubes that could be used in the digestive system. So this gives you a little bit of information on that. 7.6, this is your OpReport. Post-op diagnosis, end-stage renal disease. So this is placement of a tunneled peritoneal dialysis catheter. Okay, so peritoneal, you have to think about your body part. Peritoneal, peri, around, toneal, abdomen. So this is going into the abdomen. Okay, so your CPT code's gonna be insertion of a catheter into the abdomen. Endoscopy procedures. We did talk a little about endoscopy and scopes in the GI system. Here are some of the reasons, ulcers and gastritis, that kind of thing, as to why they might be doing the scopes, those kinds of things that they're looking at. Here's some information, the difference in endoscopic procedures, go through openings, laparoscopic, make small incisions and use trocars. So kind of, this is probably very good in kind of compartmentalizing in your mind the difference in some of the scopes. Here's some information on hernias, rectal procedures. Remember when you have EGDs, this is esophagogastroduodenoscopy, and your colonoscopies or sigmoidoscopies or proctoscopies. You're always going to code to the furthest extent. Okay, so that's one of the big rules with this. So let's see here. Post-op, patient has mild gastritis, mild duodenitis, or duodenitis, however you want to say it. They have a small gastric ulcer. It's not bleeding. And they've taken biopsies. They also have a hiatal hernia. So all of those will be your diagnosis codes. So here they start saying that this is a patient with chronic kidney failure secondary to amyloidosis with 1 week of coffee ground emesis. So this coffee ground, so the kidney failure isn't pertinent to an EGD. They're not having an EGD because of kidney issues. They're having an EGD because of GI issues. So that coffee ground emesis tells you that the patient's been bleeding some. So this gastritis is probably going to end up having to be a code that had bleeding with it. Maybe even the mild duodenitis. They may have some bleeding with them. We'll have to read the report and see. Okay, so findings. So they put down a scope. They pass it. They're telling you how far they're taking it through the gastroesophageal junction. They inspect the esophagus. There's no problems. Then they take it further. They see a hiatal hernia, so that's where they got that. Along the lower border of the hernia sac, they see an ulceration, so that's where they got that. It was not bleeding. It was photographed. The stomach proper was entered. Coffee ground material was present, so that means it had been bleeding. So I would say that gastritis will have blood. There's nothing fresh. Endoscope went into the second duodenum or duodenum. The first duodenum and bulb revealed matchy-patchy edema, no ulceration described. So there's a small ulcer and hiatal hernia biopsies. So there does not look like they had any blood in the duodenitis. Didn't have any blood. I don't see. You guys may read it more carefully and find that. So right now, I would do gastritis with bleeding. Duodenitis, I don't know that I would do it with bleeding. Then you have your ulcer, and then you have your hiatal hernia. Hey, that was a good one. Okay, OpReport, colon polypectomy. So this is just so the patient has colon polyps. It's a colonoscopy with removal of polyps. So you have to know how they removed them. So they could be snare, hot forceps. So we got to see. Cecum ascending. I'm just kind of, so 5 polyps are seen. Largest measured 1 centimeter. 3 were pedunculated. These were snared. So right there, that tells you how they took 3 of them off. 2 others, two others were smaller and, okay. So you're going to have the polyps removed by snare. If you can find that. 7B, pathology report. So that's that same. This will be just a colon polyp, hyperplastic polyps. Case 7-9, this is a sigmoidoscopy. So you always have to make sure that they did just go in the sigmoid. Yeah, so they were just, so they started out in the sigmoid, mild descending, distal descending sigmoid and rectum. So I would code this endoscopy colon, the 45330, because they went all the way to the colon. I wouldn't just do a sigmoidoscopy. And then your diagnosis code is going to be the abnormal findings on x-ray, because they didn't end up finding anything. Here's another sigmoidoscopy. And they end up doing a biopsy, so make sure you account for that. Your 1010 is the pathology of that. And I think it's going to end up being cancer, isn't it? Yeah. It's adenoma. So it's a benign neoplasm. Okay, abdominal pain, a little bit of wordy stuff. So now we're getting into probably what the diagnosis code is going to be for a few of these, or at least what they presented with. So this patient in 711 presented with abdominal pain and anemia, but they ended up with an ulcerative mass. And then pathology, I don't know what pathology, oh here. Pathology later indicates adenocarcinoma of ascending colon. So this adenocarcinoma is what you're going to use as your diagnosis code for justifying why they did the colonoscopy. So the procedure performed was colonoscopy with biopsies. I always do read in the actual procedure and make sure they did take biopsies. Here it says biopsies were obtained, so I'm good. I just always like to make sure the documentation actually backs up what the doctor claimed that he did. That's just being thorough. Here's your surgical consultation, probably recommending a surgery for that ascending colon adenocarcinoma. 11D, this is the same patient, is your path report. Oh, C is sorry, I thought that was a continuation of B. Oh. C is your OpReport, so they did a hemicolectomy, so partial colectomy, removal of the colon. Here's your path report. We should be getting, by this chapter, a little bit more familiar with this book and being able to see the advantage that it is to kind of work through the words, work through the large scenarios. You'll have scenarios on the board. You don't want to have to sit there and read and comprehend every single word. You want to be able to say, okay, it's a hemicolectomy. What information do I need to know from this? Or it's a colonoscopy. What information? Well, any scope, you have to know how far they went and what they did in there. Biopsy, removal of polyp, nothing, brushings and washings, and a bronchoscopy, that kind of thing. Okay, here is a inpatient. Remember to read your italicized, that will help you, but this is putting a patient in the hospital here. This is going to be a long case. This here, I just want to make note, they're telling you they did 90 minutes of evaluating the patient plus another 40 minutes spent in detail with the patient and their family. This must be a pretty sick patient, potentially. They use stuff like aggressive IV fluid hydration. A lot going on with this patient that's probably going to be a higher level. And because the doc is noting the times, so let's go back to our CPT a minute. Because the doc is noting times, let me get in 99233, hospital inpatient. If you look under your codes for hospital inpatient, it gives you, like 99221 is about 30 minutes. 99222 is about 50. 99223 is 70. So this doctor's telling you he spent 90 minutes plus another 40. He's going to need prolonged services on top of that. So what you're going to do is add up the total amount, subtract out what the 99223 level would be. So subtract 70 from that, and you've got 60 minutes left over that you're going to plug in for prolonged services. Okay? So that's how you would do that in the real world, and on the test or anything else. Infectious disease, I think this patient has the gastroenteritis and a lot of vomiting and stuff, and they just kind of don't know what's wrong with him. So they do a consultation, infectious disease, he's got diarrhea, he's been transplanted, I think, before, maybe a kidney transplant, a pancreas transplant, I can't remember exactly. Those are, oh yeah, here we go. Renal transplant, can't see the pancreas. I thought he had a renal transplant and also pancreatic cadaver transplant. So this patient's going to be high acuity anyway because he's going to be high risk for rejection, not do well with medications, that kind of thing. Okay, then 12C. They're going to do a scope here of his colon with multiple biopsies. What did we get as a diagnosis? Biopsy, normal colon. So we just have patchy erythema in the descending. Impression non-specific erythema, not characterized. So there's no CMV. That's what they were looking for. So I don't know. You're kind of stuck with colon disease or something. Just something really random. Probably maybe look up case 639 and see if you get anywhere with that. I don't think if you look up erythema, you're not going to be able to put that in the colon, and that's what you're going to need to do. I would also be coding that Z code for pancreatic and Z code for kidney transplants. I would also be coding diabetes too, because you have no idea if that isn't playing a factor. And then also diabetes would always play into care and management of the patient. So they did the colonoscopy here. This is the EGD here. I think they did come up with gastritis. So that now we're kind of, thankfully for the patient, narrowing the playing field for what might be wrong with him. Then we did a KUB. Remember, that's kidney, ureter, and bladder. So this is just an x-ray of the urinary tract. 74400, I think. 7440, I think. Check me if I'm wrong. I think I'm right. You need to see if they have contrast. So we know they did a KUB. Yep, barium. So they did do it with contrast. And then it's for diarrhea, the nausea and vomiting. And then I believe your 2 codes for the kidney and the pancreas transplants. Those would follow this patient. Every time I would just copy those over. Looks like this is a repeat KUB and another repeat KUB. Hopefully different days. Then a discharge summary home. Remember, there's only 2 codes. If you have no mention of time, it's the 99238. If you do have time and it's over, if it's over the right amount, then it's 99239. Okay, let's see. Now we've got OpReport of appendectomy. So this one should be fun. So you need to know if it's open procedure or laparoscopic. So let's see what they say. Post-operative acute appendicitis. Procedure performed laparoscopic abdominal exploration, laparoscopic mobilization of the cecum converted to an open appendectomy. So that's going to be a big complications. A small serosal tear in the ileum happens and it's repaired. So we're going to have several codes here. So this started out small infra-umbilical incision was made. It was insufflated. So here, that word insufflated, and you've got trocars going in. So this is the laparoscopic part of it. But here they highlight where the tearing happened, and then they had to convert it to an open. So you're going to have two codes here. You're going to have the open excision of the appendix, and then you're going to have a tear. This tear is a tear of the intestines, so enterorrhaphy, E-N-T-E-R-O, rhaphy. And then you're going to have that laparoscopic abdominal diagnostic procedure. The reason you're going to track that is because that procedure is what caused the tearing. And you probably put a 51 modifier on the rhaphy, the suturing, and you're going to put a 59 on that laparoscopic procedure. So your big dog here in the scheme of things is going to be the open appendectomy that got the appendix out. Then it was just a matter of repairing the damage that they had done. Diagnosing wise, you're going to have acute appendicitis. That's what brought him to the operating room to begin with. Then you have your complication, intraoperative puncture. I think you'll be able to put that into the digestive system. Then you're going to have an S code for injury to the small intestines, and then a Z code, Z5331, for having to convert that laparoscopic procedure to an open procedure. So I would spend quite a bit of time on this one solely because it has a complication in it, which we do see, but it brings together kind of multiple CPTs, and it brings together some new, unique ICD-10 codes. This one's very, very good practice. Okay, this next one, this is going to be a gallbladder removal. Let's see, post-op biliary dyskinesis, laparoscopic. So I just want to come down here and make sure, remember that's one of the first things I do is make sure, verify what the approach was. Was it open or was it laparoscopic? So we did a supra-umbilical or umbilical skin incision. They're going to tell me somewhere that we insufflated. Yep, the abdomen was insufflated with carbon dioxide. So I know that this was in fact laparoscopic. So that's good. That's very good. We'll keep going. 15, another outpatient consultation. We should get that one okay. This one kind of keeps on B and C. D is going to be the actual surgery that they need. Seems like B was maybe, yep, that's an ED, emergency room. And then another outpatient consultation. And then this OpReport. Read your italicized. It's hard to talk and read at the same time. They're going to do a partial gastrectomy and put a tube in. So right here, they're telling you what all they're doing. So an exploratory laparotomy would only be coded if that was the only thing done. So we're not going to use that code because other stuff was done. So this partial gastrectomy, that's going to be probably the number 1 code. Then they do a vagotomy. This is going to be its own code. And I'm writing down these codes to just kind of help you so that you'll know. Then they put a tube in. Oops. I'm not writing very neat, am I? Wait. I bet that tube, no, the tube, I think when you read, I think the tube's going to be bundled in the 43632. So then we wouldn't code extra for that because it's going to be bundled in, but the cholecystectomy is going to be memorizing my codes incorrect. So the vagotomy, and then the cols. I put the cholecystectomy by the wrong. So you're going to have 3 CPT codes here. And then you've got your ulceration and you've got your cholecystitis. This is another really good note. Really good experience to get through. You have these answers in your in the back of the book, so you should do okay. Then your intraoperative cholangiogram, that's just kind of looking to make sure that they've cleared what they needed to clear and that tubes are where they need to be. Then you have your pathology. This pathology does a very good job of highlighting the different words that you need to know, better, as good a job as I could do to help. And then you've got your discharge summary. 2 codes in a discharge summary. OpReport for a cystectomy, removal of a cyst. So this is an exploratory lap, excision of descending sigmoid colon area mesenteric cyst. So again, you're not going to code for that exploratory laparotomy. They're going in as an exploratory laparotomy, not knowing what's wrong, but once they get in, they determine there's a cyst. So you do not code for the exploratory lap when they actually do something. Here's another hemicolectomy for cancer. 18, this is an initial in the hospital. This is a weird one. Please see Dr. Sutton briefly. I was called about this woman earlier. She has a history of questionable. When we did do a history exam, she was very confused. So this particular patient, the physician's unable to interview the patient for the history and physical part. It makes that history unobtainable. It's not that she's just very confused. She's there, she's just very confused. She's still breathing and all of that. So you might be able to, depending on, I don't think you're going to have an E&M on this, and your hospital would have to determine how they were going to bill for that time. They might go on and bill with a subsequent, even though it is initial, but they really, you got to have a history. If this patient had been comatose, it would have been one thing, but they're not. Kind of makes that complicated. So here we go, laparotomy, colon, fistula. So again, we did an exploratory lap, lysis of adhesions. They have a small bowel obstruction, and they took down, which means they closed, an enterocolonic fistula. So that's what you're going to code. That was the big dog, was the enterocolonic fistula. The lysis of adhesions, you can only use that if that's the only thing done. And the exploratory laparotomy, you only code if that's the only thing done. Okay? Discharge summary for that patient. Here is tracheostomy and gastroduodenostomy going in. Seems like it was a planned tracheostomy. The patient has Crohn's. 20. Appendectomy again. You have to know whether it's open or closed acute. They're under general procedure, the right quadrant. Well, yeah, so all the skin is it's carried down through the sub-Q, the sheaths rectus. So yeah, we're cutting into muscle. So this is an open approach. Pathology report. And then 21A in hospital again. Oh my gosh, this is a long one. Don't those words, it just scares you when you see it, doesn't it? So you got to read through it to see what you can get rid of. So this is a going in the hospital, OpReport. So that was going in the hospital. Here's the OpReport for the removal of some of the cecum, and then the discharge of that patient. And this discharge goes on forever. I wouldn't even read too much of the discharge other than to see if there's mention of time or to get your diagnosis codes, because all of the middle guts from an E&M standpoint do not matter. Okay? There's probably going to be a lot of diagnosis codes on this one if it were me. They do have hypertension with your chronic, so make sure you're using the I-12 for your hypertension code. 711, this is a placement of a gastrostomy tube. You're going to have 4 different CPT codes on here. I'm going to give you these CPT codes, and then I want you to go look them up. This is kind of reverse, like the auditing. And you guys look these up and then look in the wording in the actual scenario and make them work, okay? 23, it's another in the hospital admit, and then a right inguinal hernia. Remember, you have several hernias to choose from. Your pathology. All your hernias are on that one page. This is a surgical consultation. So this is outpatient surgical consultation for a hernia of the umbilicus. And then here is the surgery for it. All right, a little bit of wordy. Goodness, this one goes on forever, doesn't it? 25 is your axillary node, so we're at the very, very back of the digestive. So this is in your lymph. Remember to, if it's left, you're going to use an LT. Your pathology. You've got a splenectomy. There's only a few that it could be. So these aren't too tough once you get on the page. There's only a few codes anyway. And then you have your bone marrow. These are just to kind of get you familiar. So I think you're good. These are just so you can read the words associated with some of these CPT codes and go from there. But I think this looks, this is okay. Remember to let me know if you need your answers. Next video will be Chapter 8, Musculoskeletal. There's only 14 chapters, so you're over halfway done in the book now. Okay, see you in the next video.